All right. Hello, everyone. My name is Michael Jones. I'm a community obstetrician in a town, Fayetteville, North Carolina. So I'm not at a university hospital. I'm a real guy down in the trenches. I had the privilege of delivering 9 babies yesterday on call. So if I seem tired, that's why. But the fun part about this is that I'll be talking about some things that aren't just restricted to a university setting or a research setting, but this is stuff that anybody in any situation throughout the US and really most of the world can do to reduce or eliminate the use of blood when we're talking about cesarean deliveries. So why should we be worried, or why should we care about blood loss at cesarean? Because C-section is now the most common surgery in the US and actually worldwide. 1 of the 3 births in the United States is by C-section. My batting average was better yesterday. I only had 1 C-section out of those 9, but it's not uncommon for me to have 3 or 4 in a given day. And nationwide, it's 1.15 million in this country. The average blood loss at a C-section is about, we call it 600 frequently. It's probably higher than that, probably about 750 cc's. And remember, like Dr. Waters said, most pregnant women are going to come in to that delivery with about 4.5 to 5 liters as total blood volume. So they're losing a lot. Nationwide, if you look at stats for transfusions, the numbers range from anywhere from 3.1% to as high as 20%. At our hospital, it's roughly about 4% transfusion rate, which is a lot. We do about 1,000 sections or so in our hospital every year. So that's 40 plus people that are getting blood after C-sections, and massive transfusions occur about 1%. So it's not an uncommon phenomenon, and it's in some sense, in some situations, largely preventable. Rates of transfusion are increasing over time. The reason for that is because the C-section rate itself is increasing over time, and the high-risk situations like placenta previa, placenta accreta, placenta procreta, all of these things are also increasing, largely secondary to the high C-section rate. And again, as Dr. Waters also mentioned, transfusion is not a benign situation. It's associated with morbidity, whether that be circulatory overload, immune suppression, and other phenomena, development of antibodies. And of course, as we all know, there are a number of patients that have clinical or religious objections to transfusions. So we want to be cognizant of the need to develop a standardized technique that lowers our risk of having blood necessary for cesarean and post-cesarean care. Historically, many physicians' perception with patient blood management has kind of been, well, we'll see what happens. We'll do what we usually do, and hopefully you won't need blood. That people get that a lot. Witnesses get that a lot when they see the doctor. But realistically, as you all know, patient blood management is a sophisticated sort of 3-legged stool where we want to make sure we take care of the patient prior to surgery by optimizing their blood count, in the operating room by controlling blood loss whenever possible, and then outside the operating room. And there's 2 phases of that with postpartum women. One is being alert and managing postpartum hemorrhage, and the other is regenerating blood and tolerating anemia. And if you were lucky enough to be in a well-equipped hospital, a multidisciplinary team approach is helpful, whether that involves the surgeon, anesthesia, hematology, the nursing staff. All of these things are necessary to have an effective blood management strategy. A lot of the work that goes into avoiding transfusion in these parturients is avoiding anemia. In our community, we have residents at our hospital, and one of them did a Screen for Anemia project. And our rate of anemia at the time a woman presents for delivery in our community is 30%. 30% of our women have a hemoglobin of less than 10 when they show up to deliver. That is the same as Afghanistan. It's terrible. We have a young community. They eat poorly. They've got bad nutrition, and there's some exposure or some prevalence of thalassemia and other hemoglobinopathies in our community, as we have a relatively high African American community. But this is a critical area where we can intervene to avoid starting behind the 8 ball with anemic patients. So we screen for anemia at the first visit, and we've encouraged everybody in our community to do that, as well as 28-week visits, because that's when the hemoglobin tends to nadir in parturient or gravida, and that's when you can intervene. So pregnant woman starts her pregnancy with 4 liters of blood. Typically, she's going to expand to about 5 liters of blood to compensate for the uterine bed, which is now getting 20% of the blood instead of 1% when she's not pregnant. So that needs an extra liter of blood, and also to compensate for the blood loss that's anticipated at delivery. That extra blood needs not only plasma, but also extra red cells, which requires 1 gram of elemental iron throughout the pregnancy or so. A typical woman gets about 17 milligrams of iron from her diet. A typical prenatal vitamin has 27 milligrams in it. It's not enough. So to Dr. Waters' point, oral iron supplementation is critical. Oral iron is not absorbed all that well. So I really, and I'm not a grits and granola obstetrician, but I really harp on my patients, please eat iron-rich food. We give them a list, find something on this that you like to eat, because iron-rich food has both the iron and the ferrous form that's more easily absorbed. It also has the folic acid, and if it's a meat product, B12, so that these are the elements necessary to generate red cells. After the first trimester, we do encourage separate oral iron supplementation for the prenatal vitamin, because the prenatal vitamin just isn't enough. It would be too big and too unpleasant. And we have a low threshold for putting people in the IV infusion clinic. So if you come in at your 28-week visit and your hemoglobin is less than 10, you're going to get referred for IV iron outpatient. Frequently we can use EPO. The real advantage of EPO is not so much that you get more hemoglobin, but really that it's faster. So typically, if we identified our 28 visit, we just use IV iron. If we have someone who we identify at 34, 35 weeks, and they're still anemic, that's when we kick the EPO in, or postoperatively. And there are many iron formulations. There used to be a tremendous reluctance to use IV iron, as Dr. Waters mentioned, because of concerns of anaphylaxis. But the new iron formulations, whether it's Injectafer, Monoferric, or Venofer, they are not prone to anaphylactic reactions nearly as often as the old iron dextran. So I think we can use those safely. Injectafer and Monoferric are wonderful because they have really high doses of iron. Typically, Injectafer has 750 milligrams, Monoferric 1,000 milligrams. They're just more expensive. So if you want to cut costs, you can use Venofer, which is anywhere between 240 milligrams of elemental iron. You'll just need more doses. But these are excellent opportunities to try to get your hemoglobin up to 11, 12, 13 prior to starting your cesarean. Okay. The next thing that we like to do is make sure that, to the extent possible, we can identify patients who are at risk of intrapartum or postpartum bleeding. And there are a number of scores that have been developed by A1 or ACOG that do a great job of that. And so one thing we do in our unit is every time someone presents for a scheduled cesarean or in labor, they get a hemorrhage score. We use the A1 score. It's in our electronic medical record. They're rated green, yellow, or red. It's right there on the labor chalkboard. And so everybody sees it. And each of those triggers a nurse-driven protocol to have medications available. If they're low risk green, we typically just have Cytotec available. If they're yellow, we have Cytotec and Hemabate and Methogen. And if they're red, we typically have all those things plus the entire hemorrhage cart, which I'll discuss a little bit later. Okay. One of the other big principles is that early recognition and aggressive management of postpartum hemorrhage is critical. Deny and delay kills people from hemorrhage. So as tempting as it is to want to believe that your patient isn't bleeding as bad as the nurse says, you have to really stay on top of it. After delivery, high tolerance of anemia, particularly in stable, otherwise healthy, non-bleeding patients, is critical. Most of our patients are that way. We don't need to have some magical number transfusion threshold. This has been one of the most difficult culture changes in our hospital. Our residents still abide by, well, they're hemoglobin 7, they need to be transfused, and we're working through the fact that the morbidity and mortality doesn't start increasing in patients until hemoglobin is really less than 5. And the other thing that I think is critical is make it easy for the doctors to do the right thing and the nurses to do the right thing. Have an inpatient anemia protocol, click the button on the computer or get the order sheet out so that everybody knows right there at their fingertips, okay, I have my erythropoietin, I have my vinifer, I have my B12, my vitamin C, etc. I just have to check the boxes and my patient gets what they need. I don't have to think about it. Okay. So this is an example of hemorrhage scoring. I have the ABOG hemorrhage scoring sheet on the side. And what hemorrhage scoring does is it allows you to prepare for a hemorrhage to the extent that that's possible. Most hemorrhages, or many, are going to be unpredictable, but to the extent that you can see it coming, you can start marshaling your resources. Okay. Because again, if we're going to engage in blood conservation therapy, timely recognition and aggressive management is essential. These people bleed heavy and fast. And if you're trying to avoid transfusion, you have to get on top of it as quickly as possible. Okay. Certain things you might need besides just the medicines, particularly for these high-risk people with previous, accretus, fibroids, DIC, etc., or take back, bring another surgeon. There's no shame in that. Because some of the things you have to do to get these bleeding controlled is technically, outside of most people's wheelhouse. Uterine devascularization is not an uncommon procedure. Cesarean hysterectomy, again, out of those 9,000 deliveries, I've probably done maybe 5 or 10 of those, which is more than most people, but still not a whole lot. So it's good to have an experienced surgeon with you. And hypogastric artery ligation, I've had the pleasure of only having to do that once. So again, nice to have another person with you that can help you if the patient's bleeding badly and you have to do a relatively complex procedure to get them to quit bleeding. Cell salvage, critical. And also the role of interventional radiology can't be understated. They are increasingly useful for helping us manage postpartum hemorrhage. Preoperatively, we can put balloons in either the hypogastric arteries or in the aorta, like the Roboa device. Or if the patient is bleeding postpartum or post-op, a uterine artery embolization can be performed that prevents the need for relaparotomy and can control bleeding in a controlled situation. So what is a C-section? 3 things: laparotomy, hysterotomy, and extraction of live fetus. So sizing the abdomen, sizing the uterus, getting the baby out. And you can bleed any of these points. Okay. So the first thing to think about is the things that really aren't necessarily in my wheelhouse, but this is Dr. Waters' game here. When you place a spinal, typically the order of things is that spinal is placed, and prior to placing the spinal, there's going to be some drop in blood pressure. The patient is front-loaded with fluid. Okay. You can actually do acute normal bulimic hemolution prior to that if the patient finds that acceptable, where you can extract some blood, then tank up the patient with fluid, have them bleed the dilute blood out, and then replace the loss rather than with IV fluid, replace it with patient's own blood. Keep the patient warm. Have the room warm. Surgeons like the room cold because you've got all this gown and what have you on, but the room should be warm both for the baby and for the patient. Put the baby on the patient. That keeps her warm too. The role of tranexamic acid historically has been used as a hemorrhage mitigation post-op, but now there's reasonably good data from meta-analyses that prophylactic administration of tranexamic acid can be used safely to reduce blood loss of cesarean without increasing the risk of thrombosis. So I certainly do this routinely with my witness patients. I think as the data accumulates, it's probably going to become a routine practice for all of my patients. And then all of our patients get oxytocin to help mitigate uterine atony. And then You can even take it a step further and give the patient rectal misoprostol to help, again, mitigate uterine anatomy so the patient doesn't have postoperative vaginal bleeding. Okay, how to make the incision. So historically, we have used fan steel incision. It's nice and low, it's cosmetic, it's cute, and it's a larger incision, and it's made sharply. We like to use a transverse incision of some sort because if you do a midline, it's ugly, it's painful, and there's a higher risk of dehiscence and hernia. So you're not going to get buy-in to do a midline incision on most patients unless it's a morbidly obese patient or there's another reason to do it. If you're going to do a transverse laparotomy, a Joel Cohen type incision is now preferred. That's a smaller incision than a fan steel incision, and it's higher up off the mons, so you get less of that mons bleeding. There are a number of perforating vessels, superficial epigastrics, and others that tend to populate down this mons area where the fan steel incision is. And so I avoid that now, particularly in the patient that's concerned about blood loss. When we do the Joel Cohen method, it's a smaller incision, doesn't go out quite as far laterally, and it's developed bluntly so that the vessels kind of stretch and get out of the way, as opposed to cutting them with electrosurgical device or with sharp instruments. Bluntly, that is develop the fascia, and then you want to stretch cephalocaudad to get the rectus fascia off the muscle. Again, that avoids a number of the perforating vessels that tend to get interrupted when you develop the transverse incision the traditional way. Okay. We also get into the peritoneal cavity bluntly instead of sharply, again, avoiding blood vessels. This doesn't sound like a big deal to most people that do C-sections because typically the blood loss is at the hysterotomy, but when we have relaparotomies, we take people back more or frequently, it's not bleeding from the uterus like everybody's worried about. It's bleeding in the incision at the rectus sheath because a lot of times people will hit a perforator on the way in, it'll spasm, they'll ignore it, or they won't notice it, and then that will become a rectus sheath hematoma, which will require, and it's pretty amazing how much people can bleed from those rectus muscles, liters of blood. So developing the laparotomy appropriately and inspecting it on the way out is critical to avoiding unnecessary blood loss. So that's getting in the belly. Okay. Hysterotomy, that's getting into the uterus. Okay. And in most cases, we're going to do a low transverse hysterotomy. There's a couple of reasons for that. Number one is that the lower uterine segment and cervix are considerably less muscular and less vascular than the uterine fundus. So you encounter less bleeding going in. Remember, 20% of the patient's cardiac output is going to her uterus. When you cut it open, that's a liter every minute. When you cut it open and you leave it open, if you're in the fundus, you're going to bleed that almost that entire liter or some large fraction of it. You only have a little bit of time to get it closed and you have to control it. So if you go in a less vascular area, so much the better. I recommend you score the incision with the knife and then get in the uterine cavity bluntly. There's a couple of reasons for that. One is that you tend to avoid interrupting blood vessels. And then secondarily, won't cut the baby. And then historically, I was always taught to open up the uterus or the uterine incision side to side. The problem with that is that you can extend out laterally, and guess what's out laterally? The ureter and the uterine artery and vein. To get into the uterine artery and vein, that's each of those vessels, 500 cc's of blood every minute. It's a lot of bleeding and a lot of trouble to close. So rather than going laterally, if you can extend the incision up and down, that will allow the incision to stretch along the fibers. It'll still get a nice transverse opening for the baby to come out, but you are much less likely to get into the uterine vessels laterally. So the cephalocaudad approach, I think, is superior from a blood loss perspective for sure. You can close the uterus either in 1 layer or 2, whatever it takes to make it quit bleeding. And this one is always hard for me. You should wait for the placenta to separate spontaneously. I like to move along during my C-sections, but realistically, there's considerable data that says that there's less infection and less blood loss if you allow the placenta to separate spontaneously, allow those spiral arteries in the myometrium to contract rather than just sort of manually shearing it off and taking it out, where you're going to have considerably more bleeding, particularly if it doesn't come off clean. So once the baby's out, hold pressure on the uterus, massage the fundus, allow the placenta to spontaneously deliver. Okay. The laparotomy accounts for 30% of the bleeding. If you take someone back, hysterotomy bleeding is 40%. So you have to inspect the hysterotomy, make sure it's dry before you leave out, particularly any lateral extensions you might have. Okay. How do we get the head out? Well, usually it's not that big a deal. If the head is right at the lower uterine segment, a lot of times a simple manual elevation is able to be done. And what you're trying to avoid, again, when you get the baby out, is you're trying to avoid an extension of the hysterotomy, either caudad or worse yet, lateral, where it can get into vein or vessels that are very difficult to control. So if the person is a repeat cesarean and the uterus is not, it's not very muscular anymore, it's very thin, sticking your hand in there, especially if it's big as mine, can cause an extension. So you can either use a head extractor or the forceps blade. That's helpful to get the baby out without making an extension. The other time that extensions are big trouble is when the head is deeply impacted. So maybe the patient's been pushing for an hour or two, the head's very low. If you get the baby out in the usual way and reach down, try to get that baby out from your usual hysterotomy, you're likely to have that very thin and sometimes infected lower uterine segment to extend either inferiorly or laterally into vessels that are difficult to control. So there are a couple of techniques that can be used and with a deeply impacted head. What we frequently do at our hospitals, we have a nurse put her hand in, push the baby's head up to an area that it's much safer to extract. That's the hand from below technique. The other thing you can do is that rather than trying to get the head, which is so deeply impacted, is you can reach up and to grab the legs and do what's called an internal pedalic version, where you basically do a reverse breech extraction. Grab the legs, pull it on down, the head will naturally elevate when you do that, and that will keep your hand from leaning back on the hysterotomy and extending the hysterotomy into a situation where you're going to have bleeding. So certainly very wise to be cognizant of that to avoid unnecessary bleeding. Okay. Cell salvage, Dr. Waters, I think, went into this in great detail. It is a matter of conscience among Jehovah's Witnesses, regardless of whether or not you have a continuous circuit or a discontinuous circuit. And as he mentioned, there's been controversy in the anesthetic literature and the hematologic literature about whether or not it's safe to use a cell salvage device when there's infection. Is it safe to use it in the presence of amniotic fluid? Because we don't want someone to have sepsis. We don't want someone to have an amniotic fluid embolism. It turns out that the data, and he's mentioned this too, really supports the fact that you can use a cell saver even in the presence of infection or obstetrical situation, or even malignancy for that matter, which is not ordinarily an issue for us. But there's not been a reported case of amniotic fluid embolism with the cell salvage device so far. It does not appear that there's an enhanced risk, even in a surgery like a C-section, which is what's called clean contaminated. You enter into the uterus, it's not a sterile organ, particularly if someone's been laboring for a while. But all the same, you're not gonna put that patient at risk of sepsis. So it's safe to use. We typically use something called a double setup. So we have a dirty suction. So when I get into the uterus and I break the water, I have my dirty suction suck up all that amniotic fluid to sort of lower the risk of putting amniotic fluid and amniotic contamination in the cell salvage collection. That's not strictly necessary, but I find it helpful. Same with leukocyte depletion filters. We use those, but again, there's no real data that says you have to. So if you don't have one, doesn't mean you can't use a cell salvage device. And I find if you get kickback from your anesthesia colleagues, ACOG just had in August of 2021 an anemia and pregnancy guideline that says specifically the use of intraoperative cell salvage in obstetrics has been shown to be feasible, safe, and potentially effective in reducing the need for transfusion. So we have the blessing of ACOG. I think it's worth using. The one thing I'll say is right now our facility is not like Dr. Waters in that we have only a few perfusionists in our hospital They're on call. Now everybody knows how to use a set up the cell saver. So again, if you think you're going to need it, you have to assess your facility's ability to pull it together on the spot. But the flip side of that is that if you can make blood conservation a priority at your facility and make cell salvage more available, then this is a useful thing, because although we like to try to predict those patients are going to bleed, we can't always do that. Okay. Early recognition is critical. And historically, we have been bad about that because we use estimated blood loss. There are innumerable studies in the literature, and every surgical specialist show that we are bad at estimating blood loss at every level, whether it's medical students, residents, attendings. We habitually underestimate the amount of blood loss, both at vaginal and at cesarean deliveries. So why do we do it? It's easy enough to actually quantitate it. And so ABOG has really made a point of that as long ago as 2019, that we should be doing QBL, quantitative blood loss. It's not that hard to do. In a vaginal delivery, that means you have calibrated drapes under the buttock, so when she bleeds, you're measuring it right there and weigh the sponges and the clots. Typically, a gram or so of extra weight on the sponge, or a gram or so clot, translates to roughly 1 milliliter of blood loss. So QBL should be a part of any labor and delivery unit or any cesarean where the institution is serious about managing postpartum hemorrhage with as little blood as possible. We give everybody Pitocin afterwards, and we have a nurse-driven protocol at our hospital where if you lose more than 500 cc's QBL, or after C-section you have more than 500 cc's of vaginal bleeding recovery, they automatically give tranexamic acid, and then they call us. And I can tell you QBL is critical because I'm not always in that hospital. And if the patient calls and says the patient passed a clot, I might stay in my office and keep seeing patients. If that nurse says your patient passed a clot and we waited and it's 750 cc's blood loss, I'm going to leave my office and I'm going to go up there and see what's going on with that patient. It really enhances the communication between the nursing staff and the doctors. And as I mentioned before, what kills people, what gets blood transfusions going, is deny and delay. And so if the nurse gives accurate information, then you have the good sense not to deny and delay. We have a hemorrhage cart put together too, so that it's easy to access the medicines and the equipment necessary to deal with heavy bleeding. And this can be done anywhere. The hemorrhage cart has Cytotec, Methodist, Hemobate, tranexamic acid, and a uterine tamponade balloon. And then finally, what causes postpartum hemorrhage? The 4 T's, right? Uterine tone, retained tissue, coagulopathy, and then trauma. So bring the ultrasound in the room, take a look, make sure there's not any retained tissue inside the uterus, either after a vaginal delivery or even after cesarean. Sometimes you can either have retained tissue or retained clots that need to be evacuated so that the uterus can have satisfactory tone to reduce blood loss. Okay, our hemorrhage cart is essential. It allows us to have quick access to our supplies. It has a refrigerator built into it for things like hemobate that require refrigeration. Should be properly labeled, and on top of the cart, it has instructions for how to use things like that Bakary balloon, the uterine tamponade balloon, that people might not necessarily be familiar with, and it has a checklist on the top so that everybody's following a prescribed algorithm for managing bleeding that may occur. Okay, and so Dr. Waters referred to the CMQCC hemorrhage protocol. We use that too. And as we implement our management, we stage the patient by QBL. Have they lost 500, 1,000, 1,500? What are we going to do? Okay, this is the exact same slide from Dr. Waters. And I guess what I'm going to emphasize is that you'll see, one thing, they are pretty aggressive about putting blood in people, even after a liter of blood loss, which is not clinically necessary. But by the time you get down to stage 3, we're talking about 10 units PRBCs, mass transfusion protocol. That's obviously not a place we want to go with our Jehovah's Witness patients. So the key is that we have to act before the patient has markedly abnormal vital signs and before the patient has 1,500 cc blood loss. And the patient has to be at peace with that, because sometimes definitive management of a hemorrhage, involves things like hysterectomies and other surgical procedures that aren't necessarily the first thing somebody thinks about when they go in the hospital to have a baby. So with our witness patients, I do have to tell them I have to be more aggressive with managing your blood loss, and that may involve definitive surgery like a hysterectomy or uterine artery embolization, that sort of thing that can impair fertility as well. But key is here, stage your blood loss, have a plan of medicine administration, calling in a second surgeon, having an OR available. And again, you have to get that hysterectomy, not at stage 3 when you're doing mass transfusion like you might with a non-witness patient, but really at stage 2, where the patient has lost a liter, but not, much more than that. Because by the time she becomes stage 3 and she's had that kind of bleeding, the cycle of hemorrhage begins to spiral. The patient gets acidotic, coagulopathic, and very difficult to control without blood products. So that's the key of this slide here. We really want to start intervening at stage 2. And this is actually an algorithm similar to that was developed by the Watchtower Society. And you'll notice, again, that you move to hysterectomy relatively quickly. So the critical aspects of managing a witness patient or a patient who does not want blood is that you don't want to guess about the blood loss. Have QBL and act quickly. Don't deny and delay. You certainly can give medicines, but really before the patient gets unstable vital signs and coagulopathic, you need to move to surgical management. Surgical management could involve placing a balloon in the uterus, uterine artery embolization, uterine devascularization, B-Lynch compression sutures, or peripartum hysterectomy. The other piece of the pie is that you need to know what your patient is going to accept. Some people will accept cell saver, which is a godsend, and these people that are bleeding heavily. If the patient's coagulopathic, cryoprecipitate can be a great help, but that needs to be obviously discussed with the patient. Same with fibrinogens and recombinant factors. Okay. And that's just the basic cesarean. There, of course, are situations, as Dr. Warner mentioned, that are high risk for significant bleeding. So I told you, typical cesarean, the transfusion rate is roughly 4%. For someone with a previa, the transfusion rate is in the teens. And with someone with a morbidly adherent placenta, it is upwards of 60% in the general population. So with those people, if you have a witness patient, you really have to make a lot of preparations, because if left to standard management, the likelihood that person is going to need a transfusion is 60%. So ideally, if someone is going to have a placenta or a morbidly adherent placenta, you find that out before you go into the operating room. That's not always possible, but again, as part of standard obstetrical care, patients should have an ultrasound. If they've had multiple cesareans and have a previa, you should be suspicious of a accreta. Those people might benefit from an MRI prior to their delivery. Accretas, I know most of you guys know this, or many, obviously. A normal placenta is going to implant above the nidobulk layer of the endometrium so that it separates off cleanly. With accretas, that nidobulk layer is damaged, and so the chorionic villi are invasive into the endometrium below the nidobulk layer where they can't cleanly separate. With accretas and procretas, the villi actually invade into the myometrium, or worse yet, through the myometrium into adjacent organs. And so this information is helpful because, number one, you have a morbidly adherent placenta, it is unlikely to cleanly separate, and your options for management, more often than not, particularly in transfusion avoidant patients, is going to involve a hysterectomy. If you know that going in and you realize that hysterectomy is going to be a bloody procedure, then again, having interventional radiology place a balloon either in the hypogastric arteries or in the aorta can be helpful. Having IR available for postpartum or intrapartum uterine embolization can be helpful. Having a cell saver can be helpful. And particularly if the procreta is present and it invades into the bladder, which is the most common, or the bowel, you may need to have a second surgeon available, such as a urologist or general surgeon, or just a second pelvic surgeon, so that the procedure can be performed as expeditiously as possible with as minimal blood loss. Have the cell saver available. And one of the other scenarios that comes up is coagulopathies, either DIC from some obstetrical catastrophe like fetal demise, abruption, or amniotic fluid embolism. Those people, you need to deal with the primary problem as quickly as possible, get the patient delivery as quickly as possible, get hematology on board, and then these are the people that you really have to explore the use of cryoprecipitant, fibrinogen, and recombinant factor 7. Remember that if someone loses a lot of blood or has concomitant sepsis, they're likely to become acidotic, have volume issues, and hypothermia. All of those impair coagulation, so they need to be treated along with resuscitating the patient. But to the extent you can be prepared for this, so much the better. We have an OR in our hospital that was designed for aortic valve replacements, but it's got cell salvage and intervention radiology right there in the room. We've asked to borrow it on these people, and that's been a helpful intervention. So if you have something like that available at your hospital, so much the better. Okay, and then finally, now our patient's delivered. Okay. You've done your best to get her tanked up before surgery. You've done a clean surgery. You've managed postpartum hemorrhage, but she's anemic afterwards. What do? We got to maximize the red blood cells she has. Remember, at this point, if her volume is normal, then really our anemia is more about oxygen delivery. And so, to the extent that you can keep her SATs above 98%, to limit her activity whenever possible. Of course, difficult with a newborn. Try not to draw too much blood, and then when you do, use pediatric tubes. And finally, really get aggressive about helping her build back her blood. IV iron, erythropoietin, vitamin B12, all helpful. So again, what we do at our hospital is we have a non-blood anemia protocol that all the residents have to do is put inpatient anemia protocol, it pops up, they populate it. And so our uptake of Vinifer has been very, very high at our hospital, almost to the point that the pharmacy called me and they said, you guys spend a lot of money on IV iron. And I said, well, it's better we spend on that than blood. So make it easy, and that's helpful. Okay, so I'm just going to wrap this up. I know we've got a long day here, but remember the 21st edition of Williams Obstetrics says famously that obstetrics is bloody business. When we deliver a baby, blood loss is probably about 750 cc's. And at C-section, our transfusion rate nationwide is about 4%. Same in our hospital. We're working on getting that down. But preparation, both before the surgery, having a standardized technique, and then managing them afterwards can reduce that significantly. Maximize your hemoglobin prior to delivery. Check early, check often, check at the beginning, check at 28 weeks. Get people into IV iron clinics as aggressively as you can. Score everybody when they show up at the hospital for the likelihood of hemorrhage, and marshal your resources as you can. Remember that involves not only medicine, but equipment, anesthesia consults, second pelvic surgeon if necessary. All right. We teach our residents, try to use a standard technique for minimal blood loss during cesarean, and we just don't limit that to witness patients. Everybody gets a Joel Cohen incision, a blunt uterine entry with cephalocaudate impression, so that they are used to a technique that has lower blood loss and manual expression of the placenta. All right, and the number one culprit, and CMQCC emphasizes this a great deal, but the number one culprit for death from hemorrhage and morbidity from hemorrhage and transfusion is deny and delay. So blood loss should be quantified, not estimated, and you should have hemorrhage kit and cart assembled, available, and stocked, so that when things go bad, even unexpectedly, they can be handled quickly so that there's a minimum morbidity from blood loss. Every labor and delivery unit should have a stepwise postoperative hemorrhage management protocol of some sort. And if you have a patient that's bloodless, you want to make sure that you intervene surgically and definitively prior to you getting to class 3 shock. So waiting until the patient's blood pressure drops to 80s over 40s or pulse is 140, or you've got 1.5 liters blood loss is not really appropriate for a Jehovah's Witness. Should intervene a lot quicker than that. Get them to the OR, have salvage available if it is acceptable to the patient. And then finally, don't freak out because the patient's blood count is 5. That's not, it should not be a transfusion trigger necessarily. Many patients, as Dr. Waters mentioned, can have a hemoglobin 2, 3, and do perfectly fine. You just need to encourage their bone marrow to correct that problem as quickly as possible with iron, oral B12, folate, epigen. Okay. And I have some resources on the slide if anybody's interested where I got some of this information from. But point being is that a lot of the more common scenarios where transfusions are currently being employed in our country, they're really avoidable at any given medical facility or hospital in the country. And it doesn't necessarily require advanced technology to serve our non-blood patients. All right, thank you for listening.